on to you, Professor, to start.
Thank you very much, and good morning, everybody. I hope you're all well. I'm going to talk you through some more very rare diseases, which is a continuation from last week. And the excuse for doing so is that they give a lot of insights into the innate immune system, so they help us to understand it. And then at the end, I'm going to talk to you about the worst complication of these diseases, which is AA amyloidosis, and a little bit about that. So this is autoinflammatory syndromes part 2. And I'm going to start with the disease which is called the cryopyrin-associated periodic fever syndrome, or CAPS. And this is a rare autosomal dominant disease that we think probably affects about 2 people per million, which was first described in America in the 1940s as familial cold autoinflammatory syndrome. And this seemed a relatively mild disease in which after cold exposure, and this could be cold or damp weather, in a clearly autosomal dominant fashion, skipping down through kindreds, people felt ill in a flu-like fashion with chills and feeling generally achy and unwell. They developed a red eye that looked like conjunctivitis. They got an urticarial rash that wasn't itchy, and they developed joint aches and felt generally very miserable within a few hours of cold exposure, and this wore off over about 6 hours. And interestingly, most of these people descended from a single common ancestor, and as they got wealthier, they moved, and they tended to move to warmer areas of the States, and they concentrated in California where the weather was better. What has become clear is that this is a disease severity spectrum, and the disease which was described in England in the 1960s, Muckle-Wells syndrome, another autosomal dominant syndrome, which in this case presented at birth with a very florid urticarial rash, accompanied in about a quarter of, or 40% of children by increasing deafness through childhood, and with a 25% risk of dying of kidney failure due to AA amyloidosis, was the same disease. And at the far end of the spectrum, there's a really nasty sporadic disease which doesn't run in families, which occurs due to spontaneous mutations, where the children have the same rash, but have really severe disease with chronic progressive meningitis, resulting in visual loss, deafness, sometimes but not always severe intellectual impairment, devastating joint destruction, and most of these children died very young and didn't survive long enough to have children. And the identification of the gene responsible for this in 2002 showed that this disease was a single severity spectrum, and in fact we're now aware that most of our patients overlap. The reason that this disease turned out to be very interesting was as we came to understand its underlying pathophysiology. But first of all, I'm just going to talk to you a bit about the manifestations. So, day to day, the disease is accompanied by a widespread urticarial rash, and I'm showing you some photographs of it here. Usually presents within minutes of birth, so the children become covered in a rash, usually get treated for presumed neonatal sepsis. People report flu-like symptoms, really bad flu-like symptoms, so fever with rigors, really severe myalgia and arthralgia. They're often described as having conjunctivitis or iritis, but in fact they can have inflammation of the eye at any level. They get an anemia, which is a mixture of iron deficiency and the anemia of chronic disease. They have chronic meningitic headaches, so these are headaches, not just central tensional headaches, but headaches due to prolonged inflammation of the meninges and also raised intracranial pressure headaches, and they have devastating fatigue. Long-term damage is bone and joint deformities, typically affecting the knees. I'll show you a photograph here of the subtle frontal bossing we always see. 20% of these patients have got finger clubbing, and in severe disease in childhood, growth retardation, delayed puberty is very common. As I've said, they get inflammation of their meninges. This can result in sensorineural deafness onsetting gradually in childhood, visual loss, and you can get severe learning damage. And they can get AA amyloidosis, causing end-stage renal failure and early death. And historically, this disease was really untreatable. There were very few options and there was no consensus on treatment. Non-steroidal anti-inflammatory agents helped a bit, but they didn't deal with the underlying pathology. High-dose corticosteroids helped, but these are 2 patients who I first encountered about 25 years ago, and you can see they're severely Cushingoid. So in order to deal with the symptoms, they needed to be on 1 milligram per kilogram of steroids, and this resulted in severe steroid side effects. You could never stop treatment. So here you can see the effect of lifelong steroid treatment. Both these patients have cataracts, and they have the full house of steroid side effects: the moon face, buffalo hump, hair thinning. They both had osteoporosis and diabetes. Disease-modifying anti-rheumatoid drugs such as methotrexate or azathioprine do nothing, and the first generation of anti-TNF therapies did nothing. The reason for this became clear actually backwards, because we treated the first patients and then understood the pathophysiology. But the mutations that cause this disease are in a gene called NLRP3 on chromosome 1. And at the time that the gene was found in 2002, we really knew nothing about chromosome 1. It's the largest human chromosome, and at that point it had 3 identified genes. But NLRP3 turned out to be exceptionally interesting. And the reason that NLRP3 is interesting is it turns out to be the means by which production of active interleukin-1 beta is controlled. And if you look at any molecular biology figures of the regulation of interleukin-1 beta, it's the standard spider plot. So you can see an awful lot of regulatory steps for regulation of what is our key inflammatory, pro-inflammatory cytokine. So it's regulated at the level of gene expression. It's regulated at the level of cleavage of the pro-inflammatory cytokine. So the pro-cytokine is pro-IL-1 beta, and it is cleaved within the cell cytocolumn to active IL-1 beta. It's regulated at the level of release from the cell, which is an actively regulated process. It's regulated at the level of the cell surface of recognition by the IL-1 receptors, and it's regulated intracellularly after signal transduction. And what this disease made clear is that there is one key step in the regulation of IL-1 beta in humans, and that is cleavage of pro-IL-1 beta to active IL-1 beta. And if that is dysregulated, the entire pathway is dysregulated, and none of the other steps can compensate for it. And it was this disease which demonstrated that, because in this disease, the mutations result in constitutive overactivation of the platform by which pro-IL-1 beta is cleaved to form active IL-1 beta. And this turns out to be what at that stage was a new mechanism which became known as an inflammasome. And this is one of the key means by which the pro-inflammatory cytokines, particularly the IL-1 family, in innate immunity are regulated. And what happens is that within the cytosol of cells which are important in innate immunity, so particularly within neutrophils and macrophages, there is a macromolecular assembly of members of the death domain superfamily, and members of this superfamily interact by shared death domains. So proteins will interact via a shared domain. So they will interact via a shared pyrin domain, or a shared caspase recruitment domain, or a shared death effector domain, and these two domains will come together. And because the proteins that make up these macromolecular assemblies will have a number of different death domains, you can get highly ordered assemblies of different components that can actually go into different macromolecular assemblies under different circumstances. And in order to activate pro-IL-1 beta to cleave to active IL-1 beta, they come together to form the IL-1 inflammasome. The cartoon I've shown here, I've shown 2 coming together, but this is not in fact right. In order to make an active IL-1 inflammasome, it's 11 procaspase 1 which are brought together, and they're brought together by bringing together NLRP3, which powers the energy for this because it's got an ACT domain in it. It's also got a ligand recognition domain, which is the leucine-rich repeats, we'll come on to in a moment. It's got ASC, which is a little connector protein, which has got a pyrin domain and a caspase recruitment domain. It's got pro-caspase 1 and another pro-caspase 1 that's brought together by cardinal. And in fact, as I've said, to bring it together, the whole thing, we don't have 2, we have 11 brought together. And when there's 11 of them brought together, this is an active enzyme which will then cleave pro-IL-1 beta to active IL-1 beta, and then that is excreted from the cell and signals. And under those circumstances, you get upregulation of the entire pathway of IL-1 beta, and you get IL-1 beta-driven disease. And IL-1 beta-driven disease is what we see in CAPS. Now, fascinatingly, IL-1 beta was first recognized as a pro-inflammatory cytokine in the 1960s by Charles Dinarello in the United States. And at that point, he recognized it was what made people feel ill with flu. And he also both induced an IL-1 beta response in student volunteers by giving them LPS, and also injected purified IL-1 beta into them. And they didn't look like they had CAPS at all. They felt like they had flu. So we don't really understand why this disease, which is driven purely by overproduction of IL-1 beta, results in this phenotype with rash. What we do understand now is that what happens in CAPS is that what you get is recognition of danger signals by the leucine-rich repeats on NLRP3, and these seem to recognize a large number of non-specific danger signals, both pathogen-associated danger signals, which are intracellular, such as components of bacterial cell walls or bacterial toxins, and also damage-associated danger signals, such as heat shock proteins, uric acid, and other damage-associated signals, possibly also including DNA and viral RNA. And this induces a conformational change, which then exposes the ACT domain, and thus then powers formation of the inflammasome, causing cleavage of pro-1 beta to active IL-1 beta, and then eventually when the signal terminates, this falls to pieces. Signaling requires a potassium efflux pump, and it is not quite clear how so many different signals can all activate the leucine-rich repeats, and whether there may in fact be some additional signals upstream of this and some chaperoning in order to induce conformational change by the leucine-rich repeats. Once IL-1 beta is produced, it's a pleiotropic cytokine and it has a number of different actions. Its actions are particularly on the bone marrow, and within the bone marrow it induces a neutrophil leukocytosis, a thrombocytosis, a T cell response, and a B cell response. It causes damage to bones, and long-term overproduction will produce a certain amount of bone reabsorption or osteopenia, and it can also cause direct damage to cartilage and cartilage breakdown. It has direct effects on the brain. So for those of you who've had proper flu rather than man flu, you'll know that one of the symptoms of flu is not just the high fever, which is directly induced by IL-1 beta, but also significant fatigue, mood depression, and pain sensitization. Those are all CNS effects of IL-1 beta. It also has effect on the endothelium, inducing release of IL-6. IL-6 is the main cytokine which induces the hepatic acute phase response with release of CRP, serum amyloid A protein, and depression of production of serum albumin. But IL-1 additionally has a direct effect on the liver in producing the hepatic acute phase response, although it's less potent than IL-6. One of the magical things that happened in the early 2000s was that in addition to identifying the gene for CAPS and beginning to understand the mechanism, we also had the opportunity to treat these patients because the pharmaceutical industry had begun to develop specific biologic agents that blocked IL-1. And we're now in a situation where we have 3 licensed drugs, all of which are licensed for the treatment of CAPS. There is anakinra, which is a recombinant small molecule which blocks both IL-1 alpha and IL-1 beta. And this is a copy of IL-1 receptor antagonist, which is in fact a hepatic acute phase response protein. And so this is made in an E. coli cell line, so it's non-glycosylated, but it is essentially a copy of a human protein. There is rilonacept, which is an IL-1 trap, which is an IL-1 receptor accessory protein and IL-1 receptor protein held together by an Fc fragment, which will bind both IL-1 alpha and IL-1 beta in the circulation and hold it there. This is a long half-life means of blocking both IL-1 alpha and beta, so it only needs to be given weekly, whereas anakinra needs to be given every day. It's phenomenally expensive. It is not actually available in Europe. It's given in the United States. And there is canakinumab, which is a conventional IgG kappa monoclonal antibody with a very high affinity for IL-1 beta, which, because it's a conventional monoclonal antibody, has a long half-life, and we can in fact get away with dosing about every 8 weeks. We did this a bit backwards, so we knew that this worked in CAPS because we actually treated the patients before we understood the mechanisms properly, and this was a paper from our unit in the New England Journal of Medicine in 2003, where we demonstrated in the first 2 patients with CAPS. Both of them were very young men with AA amyloidosis. I was worried were going to die. That giving them anakinra resulted in, within hours, in complete disappearance of their disease, complete disappearance of the inflammation, and that they have remained well now. We started them in October 2002. So this October, they would have been on treatment for 20 years, and they've remained well ever since. Since then, the other IL-1 blocking agents have also been shown in clinical trials and have been licensed for this. So these are examples of exceptionally rare diseases where the disease treatment effect is so large and so dramatic that you can demonstrate complete response to treatment using a handful of patients. And treatment with IL-1 beta blockade in all of these diseases results in improvement of symptoms within hours, complete normalization of the acute phase response with an excellent safety profile. There's a very minor increase in infections, and we are now, as I've said, coming up to 20 years of treatment with extraordinarily good outcomes. So this has been proof of principle that treatment works, that it's very safe, and that the mechanism of this disease is dysregulation of IL-1 beta production, which has been incredibly informative about other diseases. There is another acquired disease which mimics this, which is fascinating, is very poorly understood. So Schnitzler's syndrome was first described in 1962 and looks like CAPS, presenting in much, much older adults who never had it in childhood. And in Schnitzler's syndrome, it seems that there is an underlying monoclonal antibody. So these patients have an underlying Waldenstrom's macroglobulinemia or lymphoplasmacytic lymphoma, and they have production of monoclonal IgM kappa. And in some fashion, the IgM kappa appears to be stimulating the inflammasome and resulting in overproduction of IL-1 beta. And these patients, usually presenting in their 50s onwards, very gradually start to develop a syndrome that looks like CAPS, with this urticarial rash, fever, bone pain, anemia, and fatigue. And they start to get extremely miserable. And like in CAPS, they respond completely to treatment with IL-1 blockade. It doesn't make their bone marrow condition better at all, but it completely abolishes all the symptoms, and we don't need to treat their bone marrow condition. And it means that these patients, who generally by the time we treat them are quite elderly, can be managed with IL-1 beta blockade alone, don't need to be on steroids, and we can restore normal quality of life. We have about one Schnitzler's patient for every 6 CAPS patients we have. So it's incredibly rare, but it's very interesting in demonstrating that this doesn't have to be due purely to genetic diseases, but that acquired diseases can stimulate the IL-1 inflammasome to mimic CAPS. I'm now going to move on to a couple of the other diseases which are different, but just to take you through the other big causes of these very rare syndromes, because there are 4 you need to know about. We talked about FMF last time. We've just talked about CAPS. I'm now going to talk about TRAPS. So TRAPS is the genetic disease which is associated with mutations in the TNF receptor. And it's associated with mutations in the receptor for TNF. This is the TNF receptor superfamily 1A. Like CAPS, it's an autosomal dominant disease. Like CAPS, it's better recognized in Caucasians because it's rash defined, and the rashes tend to be quite subtle, so they're clearer in pale-skinned individuals, but there's ascertainment bias, and this disease is probably at the same frequency in all populations. It's just you have to be aware that we don't see the rash if you have a darker skin color, and it's present probably in about 2 people per million again. About 60% of patients give a family history. It was first described about 40 years ago. And the mutations underlying it were described in 1999. And the data we've got from it is from a big European study, and that does mean that the data we have is rather European biased. Unlike familial Mediterranean fever or CAPS, most of the families here have a family-specific mutation. There aren't particularly common mutations. There's one very, very common polymorphism which can rarely cause disease. The mutations tend to be clustered in the cysteine bridges in the extracellular portion of the receptor. This was originally thought to be very significant. Personally, my view, as the person who treats most patients in the world, is that this probably isn't very significant. It's just because this is a protein with a very, very large extracellular portion and a slightly smaller intracellular portion, and because the extracellular portion has a lot of cysteine bridges, there's just an awful lot of cysteine residues that can be mutated. And I think the preponderance of mutations affecting the cysteine residues is just because there's a lot of them, and I don't think it otherwise matters very much. The clinical manifestations of TRAPS are a little more nebulous than either familial Mediterranean fever or CAPS. So what we tend to see is individuals who have rather long-lived attacks, which can often last for a couple of weeks, with fever, abdominal pain, but it's not peritonitic. They have sort of doughy abdomens and severe but non-peritonitic abdominal pain. 63% of them get rashes, and these can be almost any different type of rash. They get joint and muscle ache, and they can get swelling around the eyes. Attacks are usually unprovoked. When they are provoked, it's by stress or physical activity, and disease tends to get worse as individuals get older. So we tend not to see it present in children until they're between 4 or 7. Children tend to have episodic disease, which comes and goes, and then as people move into adulthood, the disease can become chronic. Treatment is non-steroidal anti-inflammatories are the best pain relief. Corticosteroids can stop attacks, but you have to give a big dose, and we only give it for a few days to stop attack, and then we stop it completely, and you tend to find that steroids stop working as people get older. There was a very sad story that in the late 1990s, when we knew that this was due to mutations in the TNF receptor, and there were drugs that blocked TNF, it seemed really obvious to us that we ought to treat this disease with anti-TNFs. And we tried it, and the patients were very polite and said they felt better. And it took some time to work out that, in fact, infliximab, the antibody against the TNF receptor, probably made the disease worse. And etanercept, the Fc fragment that is a trap for TNF and binds two TNF molecules together in the circulation, probably didn't help very much at all. And what has become clear over time is that just like CAPS, and to some extent like FMF, the treatment of choice for TRAPS is IL-1 blockade, and we've now shown in trials that you get about a 90% complete response if you block IL-1, and it doesn't matter which agent you use. And this is one of our patients who took their anti-IL-1 agent to the South Pole, racing to the South Pole. So we really exposed them to maximum stress, and they managed to do a race to the Antarctic, just on anakinra with complete disease control. And we now know that we can achieve complete disease control in TRAPS with long-term IL-1 blockade in almost everybody. And the final of the big 4 diseases to talk about is a little bit different. This is called mevalonic kinase deficiency. And unlike the other diseases I've talked about, this doesn't directly target proteins that are involved in the innate immune response or cytokines. So mevalonic kinase deficiency really falls into being an error of inborn metabolism. Mevalonic kinase is the enzyme, as you will all remember, after HMG-CoA reductase in the cholesterol biosynthetic pathway. And the gene is located on chromosome 12. And there is an inborn error of metabolism in which you make no mevalonic kinase, and these children present very young with failure to thrive, and without a bone marrow or liver transplant, they die very young because you cannot survive without any mevalonic kinase at all. In mevalonic kinase deficiency, the enzyme activity is knocked down very significantly. It's about 10% of normal, but that is enough to survive. I think one of the problems that happens is that the enzyme is a bit temperature dependent, and at 1 degree rise in temperature about halves the enzyme activity. So attacks are precipitated by anything that could induce a fever, and in children that's infections or vaccination. And children tend to have worse disease than adults because children are more inclined to get fevers than adults. It was initially thought that the problem with this disease might be due to accumulation of substrate and that you were accumulating mevalonic acid, which is the substrate for this enzyme. But this is clearly not the case now, and we think this is actually a problem with a failure of flux, and it's a failure of flux down the isoprenoid pathway, and this is resulting in decreased production of a number of isoprenoids, and this is resulting in decreased prenylation and prenylation of a number of general proteins. And you may or may not remember from what I showed you last week in FMF that insertion of general generated proteins into the cell membrane seems to be important in regulation of pyrin, and we think this is how this ties in with mevalonic kinase deficiency, and that if you don't put small crenellated proteins into the cell membrane, you can't get proper activation of Rho-RET GTPases, and that this then interferes with production of IL-1 by resulting in overactivation of the pyrin inflammasome. So I'm showing this here. Essentially what we think happens is that you get impaired enzyme activity. This results in decreased Rho-RET GTPase activity. This results in impaired phosphorylation of these protein kinases, and this results in decreased negative regulation of the pyrin inflammasome and overproduction of IL-1 beta. So probably mevalonic kinase deficiency somewhat ties in with FMF and overproduction of IL-1 beta, but it's a very different clinical disease. And what we see in really bad mevalonic kinase deficiency is shown here in pictures of two adults. This is one who took a selfie, the height of an attack, covered in rash, pouring sweat. This is somebody else with a very characteristic maculopapular rash at the height of an attack. And so clinical features of mevalonic kinase deficiency. This is a disease that classically starts in the first 6 months of life, and it can look very like inflammatory bowel disease with lymphadenopathy, particularly cervical, but it can be generalized, a lot of diarrhea, vomiting, abdominal pain, which can sound very like a history of ulcerative colitis or Crohn's. They can get hepatosplenomegaly. They can get bloody diarrhea. They get an acute phase response. They get this typical maculopapular rash I've just shown you, and they get systemic inflammation. And during the attack, but not between the attack, you can measure mevalonic acid in the urine. That's a really useful test, but it's technically very difficult to do. It needs to be done in a specialist biochemistry lab. And it's usually done in labs which look for inborn errors of metabolism for neonates. Complications of this, you can get interstitial adhesions. They may get retinitis pigmentosa. They can very rarely get macrophage activation syndrome, which is potentially fatal as an indication for bone marrow transplantation. And they get AA amyloidosis, which I'm going to talk to you about in 1 minute. Again, the treatment of choice is anakinra. Just pointing out to you here that anakinra is our go-to drug because it is the cheapest of the IL-1 agents for us. Cheapest I use here in a rather laughable form because these drugs do cost thousands of pounds a year. It's a once daily injection. There is a risk of local injection site reactions, which I've shown here, which disappear in the first 6 weeks. There is a 4% risk of anaphylaxis, which we can treat with desensitization. There is a small risk of neutropenia, which is usually very mild and which goes away if you reduce the dose. There is a slight increased risk of infection, which tends to be trivial. The major problems are that it's low pH and the injections are a bit sore, and that it's a fussy drug that needs to be stored in the fridge and cannot tolerate being stored for a prolonged periods of time, more than an hour or two at room temperature. One of the things that we did with these 3 linked diseases of familial Mediterranean fever, mevalonic kinase deficiency, and TRAPS was we did the first drug study in which we managed to combine 3 very rare diseases in a drug study, not because we thought the diseases had anything to do with each other. We know that clinically they're different. We know that their genetics are different. But because we know their treatment is the same, we know that their common effector pathway in terms of making people ill was the same, which was IL-1 beta. And we combined them together in a single study where we used the IL-1 beta blocking drug canakinumab to demonstrate efficacy. And this, which was a drug study done with Novartis, actually resulted in licensing of canakinumab for these 3 rare diseases using the efficacy data from each of the diseases to back up the other rare diseases and combining safety data. And this meant that we could actually run a randomized controlled study in 3 exceptionally rare diseases and get this through licensing using only 180 patients with 60 in each disease arm, which was recruitable around Europe. And this is demonstrating the efficacy data for each of these agents and showing that the number of patients who stayed out of flare in placebo was very low in grey and was knocking 70% in patients who were on a big dose of canakinumab. Very quickly, anakinra seems to work for all these patients. Anakinra binds to the IL-1 receptor. There is the IL-1 receptor antagonist, which is what anakinra is a copy of. So we knew that we would be looking for the disease which was deficiency of the IL-1 receptor antagonist, so deficiency of our own production of anakinra. What Julie found is called DIRA, deficiency of the interleukin-1 receptor antagonist, and because medicine is endlessly fascinating, it does not look like CAPS, TRAPS, or mevalonic kinase deficiency. It is a disease which presents immediately after birth with a psoriatic-looking rash, a pustular skin rash, and with sterile, what looks like osteomyelitis affecting these babies. So it looks entirely unlike the diseases that we treat with this. It's a recessive disease because you need to knock out both copies, but it does respond completely to anakinra. This is this baby. This is shown with clinician after a week of treatment with complete clearance of their skin, and you can see a much happier looking baby. And then I'm just going to touch on quickly and say one of the other lessons we've learned is that some acquired diseases turn out to be due to mutations in these diseases that affect autoinflammation. And so this is a disease called DARDA2, which turns out to be due to mutations resulting in deficiency of adenosine deaminase 2, which is an enzyme involved in autoinflammation. And this is fascinating because this is a genetic disease which causes early onset vasculitis. It looks like pediatric polyarthritis nodosa, but it is in fact an inherited disease. And it means that we are now much more aware of the fact that what looks like vasculitis and chondritis are now diseases for which we will go looking for genetic causes in children, but we're also now much more aware that we will also go looking in adults because these genetic diseases often present as form fruits in adults with late presentation. I'll skip that. So I talked to you about amyloidosis. So amyloidosis is a disorder of protein folding in which proteins that should circulate in a normal conformation in the blood refold into a fashion which means that they have the potential to autoaggregate via epitopes which are very rich in beta-pleated sheet and form protofibrils and then fibrils which drop out of the circulation, accumulate in the extracellular space, and very gradually clog the body up. There are at least 30 different proteins which will form amyloid in man, and in the test tube you can push any protein to form amyloid fibrils, synthetic amyloid fibrils. There are 13 different proteins which will form systemic amyloidosis in man. Some of them are inherited, some of them are acquired. When the amyloid fibrils form, the major constituent is the refolded protein peptide, and that is identical in the amyloid. We don't see mixed fibrils. They've almost always got exactly the same protein making it up, but there are some additional constituents which help in the formation of the amyloid and keep it stable. One of those is serum amyloid P component. There are also some glycosaminoglycans, and there's some other proteins which add to it. They are not necessary, and you can form amyloid fibrils without them, but in vitro they're always present. Once the amyloid has formed, it's very stable. It's gone over a thermodynamic hump. It's non-covalently associated. It's in an extremely energy efficient state. It's very difficult for the body to clear away. It also is very non-immunogenic. It's not really recognized as being a problem. So amyloid tends to accumulate, and as long as there is a supply of fibril precursor proteins in the circulation, it tends to gradually get worse. And the only treatment at the moment really is to try and turn off the supply of precursor proteins and then hope that it's very gradually cleared, either by proteolysis, but more likely by active clearance by macrophage. In AA amyloidosis, the fibril precursor protein is the acute phase reactant made by the liver serum amyloid A protein. And AA amyloidosis is a rare complication of chronic inflammation. This is a renal disease, and almost all patients will present with proteinuria kidney disease. And at presentation, 57% of patients will have nephrotic range proteinuria, 10% of patients will already be in end-stage renal failure, and a further 20% of patients in our series progress to end-stage renal failure. But this is potentially reversible if you can treat the underlying chronic inflammatory disease and turn off the inflammation. And this is why it's important that any patient with chronic inflammation is always monitored with urine dip. Most patients are diagnosed by a kidney biopsy and then by staining of the tissue with the aniline dye Congo red, and you get this characteristic appearances under polarized light with apple green birefringence. So as I said, The amyloid precursor protein is serum amyloid A protein. It's an acute phase response protein which rises and falls in parallel with CRP, and it can go up more than 10,000-fold. So in health, circulating levels of serum amyloid A protein are about 0.8 milligrams per litre, and with a good going acute phase response, it can peak well beyond 2,000 milligrams per litre. It stays up as long as IL-6 and IL-1 levels are high, and then it falls with a half-life of about 12 to 13 hours. It's an apolipoprotein. There are, in fact, 3 isotypes, but it's only SAA1 and rarely SAA2 that forms the amyloid, and it's synthesized almost purely by hepatocytes, but also a little bit by adipocytes, which is one of the reasons that you see inflammation in association with obesity. This is the relationship between CRP and SAA. You can see that at low levels of inflammation, the relationship is almost linear, but at higher levels, it's very, very rare to see a CRP much above 500, whereas we can see SAAs going above 1,000 and occasionally above 2,000. AA amyloidosis seems to be getting less common. It's a disease with really quite difficult to understand incidence. In the 1980s, it was very common in the Scandinavian countries that everybody had a post-mortem, and that gave us some quite useful data. So in patients with known chronic inflammation, such as rheumatoid arthritis, somewhere between 5 and 17% of those patients had evidence at post-mortem of AA amyloidosis, but less than half of them had any clinically overt disease before they died. We have known for many years that AA amyloidosis is very rare in the United States compared to Northern Europe. We don't know why. We know that from the Armenian diaspora of the early 20th century, when the Armenians after 1917 left Armenia, and a large number came to Europe and a large number went to the United States. Familial Mediterranean fever is very common in Armenia, and at that point it had no treatment, and 60% of patients with untreated FMF get AA amyloidosis. But the Armenians who went to the United States took with them their untreated FMF and their nasty FMF, but they didn't take with them AA amyloidosis, whereas those who went to Europe did. And we don't know why. We don't know what the environmental factor is, but that seems to persist. And AA amyloidosis remains very rare in the States, despite them having as much chronic inflammation as the rest of us. Over the last 40 years, AA amyloidosis has got very much less common. We don't know whether that's environmental factors and the rest of the world getting more like the USA, but it's more likely that it's better treatment of the major causes of chronic inflammation. And certainly in the 19th century, AA amyloidosis was a complication of tuberculosis and untreated chronic infection. That's now almost completely gone away because of better treatments for infection. We're now seeing much less rheumatoid arthritis because of better treatment for rheumatoid arthritis, with the availability of biologics that target rheumatoid arthritis much more effectively. And what we've seen over the last 20 years is that in the large UK centre, where we see all of the UK's AA amyloidosis in general, AA amyloidosis has fallen from being about 10% of our new referrals to about 2% of our new referrals. And in the fever clinic that I run, nobody has ever developed AA amyloidosis. And that is because that was why we set the fever clinic up, to stop anybody from developing AA amyloidosis. So if you treat people aggressively and don't let them get inflammation, you can entirely stop AA amyloidosis from appearing. Any disease that causes chronic inflammation can cause AA amyloidosis, and I show here a chart of all the reported causes. So you can have infections, you can have any cause of chronic inflammation, you can have hereditary fever syndromes, which we've been talking about today, you can have malignancy, particularly lymphoma, some solid tumours, and you can have unpleasant inherited diseases such as cystic fibrosis or sickle cell disease, which predispose you to infection. What we have seen in the London Centre is that the major causes have changed over time. So we see far less inflammatory arthritis now, reflecting better treatment. When we do see infection, it's the untreatable causes of infection. So we see complications of spinal cord injury, where people have paraplegia or tetraplegia and have chronic skin or urosepsis that's very difficult to treat. We see a bit of extensive bronchiectasis that's very difficult to treat. And otherwise, what we're seeing now is increasing unknown causes, so we don't know why they have chronic inflammation. A full workup for pyrexia of unknown origin has not resulted in a diagnosis, or we see it in association with morbid obesity, where we think the problem is that their adipocytes are making IL-6 and SAA, and the treatment for that is actually bariatric surgery to try and get them to lose weight. Once people have got AA amyloidosis, the predictor of whether they will survive or not is how well you can control their inflammation. This is from the New England Journal in 2007 when I published our experience, and this divided our patient cohort up into octiles, depending on average for each year how well controlled their inflammation was, and this is the median SAA per year by octile. And you can see that the patients with the worst controlled inflammation and the highest levels of inflammation had an 18-fold higher risk of dying than patients with the best controlled inflammation. But if you look at the two lowest octiles, the patients with the best controlled inflammation, who had levels of inflammation that is the same as healthy blood donors, were 4 times less likely to die than the patients who had median levels of inflammation of 4 milligrams per litre, which equates to about 4 milligrams per litre of C-reactive protein, so which would in most group practices be regarded as extremely good control, showing that once you have amyloidosis, you want to have totally controlled inflammation all the time. So you go for very, very aggressive treatment to control their inflammation, and you keep it controlled all the time. And we do that by targeting the underlying disease, and you do that by aiming for complete control of the underlying disease all the time. And when you don't know what they've got, you do that by targeting their CRP and SAA and treating them to normalize that all the time. And our treatment regimes, therefore, are largely aimed at making a diagnosis and controlling the diagnosis. And I'm going to finish there and say, I hope that was useful. I've talked you through the rare autoinflammatory diseases, which are useful partly because if you see someone, these are treatable and you can transform an outcome for the individual patient, but also because they let us understand an inflammation in a way, an innate immunity in a way we haven't before. And AA amyloidosis, because it is the worst outcome of chronic inflammation, and because we can prevent it from progressing with effective treatment. Thank you very much.
Thank you so much, Professor Lackman. Shall we turn to questions now?
That'd be great.
Okay, so guys, you can feel free to unmute yourself one by one, or write a question in the chat, and I will read it out to the doctor. Any questions?
Doctor.
Hi.
Hi. Thank you so much for this highly informative lecture. Do you do any genome sequencing?
So what we usually do is we do a panel of the known knowns. So our main diagnostic practice is to do a panel of the 24 genes that are known to be associated with disease. And there are a number of reasons for that. One is that, particularly because I do mixed practice and I tend to do quite a lot of adult practice, we're interested in somatic mutation because we see a number of diseases in which we see somatic variant causing late onset adult presentation. And when you do genetic sequencing, you have a choice between reading widely or reading deeply. And if we read too widely, we don't get enough depth. We're not reading enough separate cells. So in order to pick up somatic variation, you can't do whole genome. You have to choose. It's like nuclear physics. You can take one or the other. The other thing is that in diagnostic practice, which is what to a fair extent I'm doing, you need to be able to interpret your results. And the difficulty with reading too deep, too widely, is you get too many results that you can't interpret. So although we cut off at 1% of the population, say if a mutation is present in 1% of the population, we won't report it. And if it's known to be benign, we won't report it. For each, by the time you start doing a big panel, your chance of picking up rare variants starts exceeding 10% for a healthy control. And most of these rare variants, we don't have enough data to say whether they're going to be significant or not. So you can't effectively report them back as being of any meaning without having done deep phenotyping on the patients. So the short answer is we tend to do panels because in clinical practice they're more useful. We can do whole exome, we can do whole genome if in selected individuals for which it's useful, but that is essentially a research tool. It takes about 6 to 8 months to get the results back. And what we actually get back is a data file, which we then have to interpret. And it's a hostage to fortune, because you have to give people the best interpretation you've got now, and tell them that time will make a liar of us.
Okay, thank you.
We have one more question from Saria. How often do we see these rare conditions in practice?
It's a really good question. And the answer is slightly, it depends on your practice. So the difficult thing is being out there in general practice, or in general pediatrics, or in general rheumatology, and finding one amongst the infections, amongst the other causes. And these are genuinely rare. So we think that they are probably, if you add them all up, about 10 per million is probably about the prevalence. But they come into A&E because many of these diseases really hurt. They come to pediatrics because they petrify their parents. And when you turn it around and say, with these patients before they're diagnosed, how heavily do they use health resources? They use them very heavily. So they will have had about 10 secondary care contacts a year before they're diagnosed, and they will have had an average of 5 wrong diagnoses. And the wrong diagnoses aren't the GP saying you've had a viral infection. You know, this is juvenile arthritis, vasculitis. You know, these are serious wrong diagnoses. So what we tend to say to the GPs in the UK is you will probably see one of these in your career each. But they will have taken up a lot of resource and a lot of worry before you diagnose them. But to some extent, my argument is this is like childhood leukemia. You want to spot this because this is a red flag, where you can absolutely transform outcome. These are really, really high value diagnoses, because with the right diagnosis and treatment, you can give people a normal life.
Thank you so much, Doctor. I had a question myself. How often do we, in your practice, you had to refer people for surgery in their joints, if that's needed?
So it's relatively rare in the autoinflammatory diseases, and it depends a bit how long they've been untreated. So the majority of people in these diseases for whom we've had to refer for joint replacements, I honestly think it's 30 years of steroids they had, and that they had terrible steroid-associated joint and bone damage. What we tend to see on the autoinflammatory diseases is very, very, very florid joint inflammation with attacks, which settles between, rather than the slower bone destruction that you'd see with rheumatoid arthritis. So it's relatively rare.
Thank you so much. We have a question from Sabina. Which complications of AA amyloidosis is best reduced after anti-interleukin-1 therapies? Is anakinra effective for amyloidosis? Or?
So the treatment for amyloidosis is any treatment that turns off their acute phase response in a sustained and safe fashion. So there is no treatment for amyloidosis, because amyloidosis is the complication of sustained inflammation, and it doesn't matter what caused the sustained inflammation. So once you've got amyloidosis, it doesn't matter whether the driver was infection or rheumatoid or autoinflammation or a lymphoma, because when the liver makes an acute phase response, it's responding to the pro-inflammatory cytokines, and the response is the same, whatever the driver of the pro-inflammatory cytokine production was. So there is no treatment for AA amyloidosis. The treatment for AA amyloidosis is to target the underlying disease. That said, the cytokines the treatments which target the pro-inflammatory cytokines are often helpful and are often useful in terms of having a lower side effect profile than the much broader non-specific immune suppression that we have used historically, such as steroids or disease-modifying anti-rheumatoid drugs. But they don't always work. So if you don't know what you're doing, and I frequently don't because I don't know what the underlying inflammation is, it is reasonable to try anakinra or a drug which blocks IL-6 But you try it and you look at what happens to the CRP and their SAA, and if it doesn't work, you stop it. Because it can only work if you turn off the acute phase response. The treatment is essentially turning off the tap of the supply of the precursor protein, which is serum amyloid A protein. And if you can't measure that, CRP. And if the tap isn't turning off, the drug is not going to do anything else, and you stop it and try something else.
Thank you so much, Doctor, for the extensive answer. We can wait for a few more questions. We've got 9 minutes left to the end of the hour. Feel free to unmute yourself or write in the question box. Just give it a few more minutes, and if there are no questions, then... Oh, there we go. So, Julius asking, how do you treat patients with atypical hemolytic uremic syndrome?
That's cheating. That's quite different. That's a complement disorder. So if it's one of the acquired ones and it is in the end coming down to the membrane attack complex, you would use eculizumab, which is what targets that and is phenomenally expensive. So this is a completely different disorder. But that has proven remarkably effective. That really makes my drugs look cheap. That is not completely safe because you are then taking out your complement pathway, which does put your patients at significant risk of bacterial infection. So you have to have vaccinated them beforehand. And the practice here is that eculizumab is used to salvage renal function if you can. And unfortunately, many patients who present with atypical HUS, their renal function is unsalvageable by the time they present, and it is then used in order to protect from renal transplant, and you may then need to use it very long term. But it's used only in very specialist settings because long-term use of eculizumab, 1, is unbelievably expensive, and 2, is very risky because you are taking a risk of significant increased risk of bacterial infection for long-term protection of the kidneys. So you do need to make sure they're vaccinated and they are actively monitored for that.
Thank you so much, Doctor. We've got 2 more questions. Rahim asking, what is the difference between primary and secondary amyloidosis? I think they want just a brief.
Yeah. So these are old-fashioned terms which professional amyloidologists object to, but we just cannot get out of the literature. So essentially, it tends to be used that primary amyloidosis is used for what I would call AL amyloidosis. So my preferred terminology is to go with what the Amyloid Nomenclature Committee says, which is all amyloid is named according to its precursor protein. There is to some extent no primary amyloidosis. It is always, we name it for where the protein comes from. And it is therefore named as coming from light chains, which is what used to be called primary amyloidosis, and where there is an underlying bone marrow disorder and it is monoclonal light chains that are forming the amyloid. That is the commonest type we see and the most lethal. Complicating chronic inflammation, which is what used to be called secondary amyloidosis, used to be very common now, isn't it? Inherited, where there are usually point mutations that destabilize a protein and mean that it's more inclined to form amyloid. And there are a number of different proteins that can cause that, either causing neurological damage or liver and kidney damage, and they're named for the proteins which have the mutations. Transthyretin, which can cause amyloid depositing in the heart and to a lesser extent in the carpal tunnel, and that is a disease particularly of men and older men. And then you can get amyloid associated with pt2 microglobulin in long-term dialysis and in a variety of other causes. So primary was what we would call AA amyloidosis associated with bone marrow disorders. And it's a source of endless frustration that we can't stop people putting it into papers.
Thank you so much, Doctor. We've got a question from Mo. How prolonged should an infection be for amyloidosis to occur?
So that's a really good question. So the median time between developing chronic inflammation of any type and presenting with amyloidosis is 20 years. But when I plotted it, that graph is almost completely flat. So although the median is 20 years, There are some individuals who will present with their amyloidosis within 18 months, and there are other individuals who have had chronic inflammatory disease for 60 years before they present with amyloidosis. So usually it takes quite a long time, but you can do it very quickly, and you are not safe if you've had inflammation for 20 plus years and you haven't got amyloid. You might still do it next week. So the problem is it's probably a nidus event. It's like growing crystals in a test tube, if you remember doing that. Once you've got a little tidy nidus, and that is probably a chance event when two proteins meet together and cross-stabilize each other. Once that happens, it progresses, and we don't know why that first event happens. That may well be chance, and then you're on a very difficult road as soon as that starts. We also know that age is a risk factor, so the older you are, the more likely you are to form amyloid. So children are pretty protected. You don't want to start getting your chronic inflammation when you're old because you're more likely to do it.
Thank you so much, Doctor. We've got more questions coming in now. So someone's asking, can you live a long life with amyloidosis?
It can regress. So if you can turn off the supply of the amyloid fibrin precursor protein, so that you're not making any more amyloid. If there isn't too much organ damage, so if you're not about to go into multi-organ failure, the amyloid can regress, the organs can recover, and you can, in theory, go back to normal. It doesn't happen for everybody, but yes, there is the potential for very, very, very substantial recovery or even normalization of organ function. We do have people who are essentially better, but we never stop monitoring them because they've almost certainly got a scaffold of a little bit of amyloid sitting in their tissues. And we're worried that if their disease ever recurred, they'd lay the amyloid back down again very rapidly in weeks, not years. So in theory, yes, you can. One of the reasons why we treat people quite aggressively. Unfortunately, a lot of people, particularly with AL amyloidosis, the bone marrow type, present to us with very advanced disease. And we still have about a 20% mortality in the first 6 months after we see them.
Thank you so much. Ted is also asking, there's no cure for it. So what is the best treatment that you suggest?
So at the moment, the best treatment is to aggressively target the underlying condition that is resulting in production of the amyloid precursor protein, which is why you have to type the amyloid. So there is no treatment for amyloid. You have to say, why have they got this amyloid? We're going to target the reason that this patient has this type of amyloid. So in AL amyloidosis, it's chemotherapy. In AA amyloidosis, it's turn off their inflammation. Why have they got inflammation? In hereditary amyloidosis, if the variant protein comes from the liver, it might be a liver transplant. There are some new treatments where we can actually turn off, with gene silencing therapies, the particular gene. This is a different one. Combined with best supportive care. The holy grail of amyloid treatment, for which there's been a lot of research, but which at the moment we haven't got an effective drug for, would be a means of clearing the existing amyloid deposits. And there's been a lot of interest in using antibodies to do this, to try and reduce the whole body amyloid load, actually make your patients much more robust, make their organ function much less vulnerable, and then target the underlying disease when you could afford to be somewhat more brisk and rougher with it. Particularly when we're using chemotherapy, we have a problem. Patients are very, very, very fragile. And they have very fragile organ function, and you want to give them systemic chemotherapy, and that's more a good mix. But at the moment, it is trying to target their underlying disease, support their organ function, not destabilize their organ function or result in increased treatment-related mortality, but get a complete clinical response. And if we could target their amyloid before we started doing that, we think treatment would be easier. But this has been going on for the last 25 years and we still don't have a drug.
Thank you so much, Doctor, for such an informative lecture. I've really enjoyed it myself as well. If there are no more questions, I guess we'll end the lecture there. Okay. It's been really a pleasure having you with us.
Thank you very much for all your attention and good luck with everything.
Thank you. We're getting a lot of thank yous in the chat. So I'll end the lecture now.
Okay. Bye-bye, everybody.
Thank you, Doctor.
Recording stopped.
Bye-bye.